Well, welcome everyone. I'm Lynette Demers and I work for the Digital Medicine Society, and I'd like to welcome you to this launch event of the Virtual First Care Transitions Toolkit. And I'm very excited to be finally doing this event after months of work. On behalf of the impact members, you can see listed here on this slide, have been really working hard to bring this resource toolkit to you. So today we'll be talking about digital medicine, we'll be talking about virtual first care, and we'll be going through not a book report, as they say, of the resources, but hearing from the people that actually created these resources and have implemented many of the strategies in practice. So I'd like to welcome you again and introduce the Digital Medicine Society to you. So again, the Digital Medicine Society is a relatively new organization. We just had our 3-year anniversary, and our purpose is to advance the safe, equitable, effective, and ethical use of digital products to optimize human health. So why this? Why now? Well, as many of you on the line will know and appreciate, that this field is moving so quickly, and there's so much need for a multi-stakeholder group can get together and really put some boundaries and standards together around what does good look like, what does safe look like, what does effective look like. And one of the things that DIME does so very well is convene stakeholders from all the different perspectives in the ecosystem. As you can see on this graphic here, Digital Medicine Society sits at the intersection of healthcare and technology. So we're not advocating on behalf of digital in one hand and healthcare in the other, but it's really bringing the stakeholders together to figure out what are the problems that need to be solved, and where is the sense of urgency around putting some standards in place and best practices and really building the knowledge base. And so that can look like, I mean, many of you on the line are working in clinical trials, working in healthcare. There's so much need right now to do projects around understanding inclusivity in this new field of digital virtual clinical trials. There's so much need around understanding what does a very robust evidence plan look like for a new digital measure that might be used first in clinical trials and then next in healthcare. And this is moving so quickly that one of the things I think I'm so excited about with DIME does is get people to the table who may not run into each other in day-to-day life, and really roll the sleeves up and create these tremendous resources that are publicly available to advance the field. So again, I keep saying sense of urgency, I keep saying timeline, and I think that that's one of the things that drew me and a lot of people to the Digital Medicine Society and the work that we do, is that there's right now this field is moving very quickly, and as many of you in the field know, we're sort of at this discontinuous phase where things move so slowly for a long time, and then boom, we have a pandemic or we have other events happen that really accelerate. And this is the opportunity to either mess it up royally and digitize poor processes, or leave people behind, or to get the right people together in, as you can see on this graphic here, build the community, bring stakeholders together so they can understand each other's perspectives, create a common language, common standards, and identify where are the barriers that can be solved in a pre-competitive way. So figuring out those greatest challenges. Then it's the sleeve rolling up work. We do things on a project basis. And again, this clinical quality work on a tech timeline. Our clinical colleagues hold us to the standards of robust evidence and scientific method, at the same time as realizing that this field is moving and it's going to move whether or not we set these standards. And so really getting ahead of this, publishing those resources, getting out into the community and presenting, disseminating the publications and work that we do publicly to all the stakeholders. And I think that that's what I'm most proud of this work. And it definitely is very true in healthcare, that many of you are here because probably maybe 5 years ago, I'd heard of telemedicine myself, and the VA has been doing it for ages, but it was really a way to give access through video chats or video visits. And it wasn't what I would call transformative, but the last couple of years have really shown us that this industry, healthcare, is ripe for transformation. So the other thing I'd like to tell you about today is Impact. So Impact was formed about a year and a half ago in January 2021 as a joint initiative of the American Telemedicine Association and the Digital Medicine Association. And again, Impact is a community of like-minded folks working across the different dimensions of the ecosystem to figure out where are the barriers and how to move forward and grant better access to this concept of virtual first care. So we've moved really quickly from the concept of telemedicine as some virtual visits and a way to extend physicians across geographies to this idea that we can serve patients' needs in a way that is really decoupled from our traditional bricks and mortar, bringing to bear all of the clinical analytics and data infrastructure to really, I say, superpower our clinicians and clinical workforce in order to deliver that care. So the members on this screen here are the founding members, and you can see they do come from across the industry. We have payers, we have the purchaser and employer representatives, Mercer. We've got folks who are working to develop the component pieces that are necessary, so the infrastructure and the devices that make digital medicine possible, and then legacy healthcare systems that are really working hard to figure out how to deliver virtual care in a scalable way, as well as numerous companies coming online who are doing that, I'd say, very courageous work of starting with this greenfield concept of healthcare that is built around a patient need and decoupled from so much of what we think of as the bricks and mortar and other infrastructure of healthcare. So again, that sense of urgency that especially with healthcare right now, we have a very short window to get this right. And so these folks have come together in a pre-competitive way to solve some of these biggest problems to the safe and effective access to virtual first care. So before I get into the meat of this discussion and what everyone has come for, which is to hear about the care transitions work that this group has done, a couple notes of housekeeping. So none of you are new to Zoom, but I just want to make sure that everyone knows that this session is being recorded. So it will be available very shortly after this presentation online. So please forward it to your colleagues if you think they might be interested. We really like to foster an active Q&A session. So a couple options. During the Q&A session at the close of this event, you can raise your Zoom hand to be called on for a live to ask your question live, or you can at any time during this presentation type in your comments into the chat box. And what else do I want to tell you? Oh, very important. So this is all about resources that we're creating that are now available live on our website. And as we talk about these resources, the DIME team will be putting the links to these resources in the chat box of your Zoom screen. So make sure you check those out because that's your, those will be your teasers. All right, so we talked about this concept of virtual first medicine. Before I pass this off to some really exciting conversation, I really want to make sure that people appreciate what we're talking about when we say virtual first care. And I'm actually going to read this, this definition, because the very first body of work that the Impact team did was to define virtual first care. And it's defined by a multi-stakeholder group, so very important everyone's on the same page, as medical care for individuals or communities accessed through digital interactions where possible, and more is possible every day, guided by clinicians. This is medicine, integrated into a person's everyday life. So what a vision, right? And it really captures it. And more specifically, this really means that patients should be able to access care, initiate care from any time of day, wherever they are in their lives. Meaning we're decoupling the act of healthcare and the work of healthcare from the cadence of regular scheduled visits, because healthcare happens during people's life day to day. Second, means that we're intentionally selecting sites of care and providers. We're not driving everyone to a building. We're not insisting that the care interaction happens in one place or other, but we are actually driving it based on the need of the patient and the clinical setting. Decoupling again from the physical infrastructure. And then, of course, patients need more than procedures and medicines. And many of these models on this, the companies on this slide and others working virtual first care really started driving towards a complete solution for healthcare. So not procedure-based, again, decoupled from the intervention and looking at what patients need to get well on their, whatever their part of their journey they're in. It could be psychological support, could be nutrition, other things like that. And then finally, before I move on, I think there's really no question that in order to advance any new healthcare model, we have to ensure that we are following the adherence to healthcare laws that protect people, setting the standards for clinical care, as well as privacy, data security, and other emerging concerns, and making sure that that's possible. So before we move into a deep dive into the resources, I'd really like to introduce two wonderful people to talk about what we mean by virtual first care, and then give us a sense for how we start to integrate this model, this very exciting model, into the healthcare system, or a healthcare system that works so much better. And I started thinking I would introduce them and read their bios, but I'm going to pass this over to Jen Goldsack to introduce herself and let her take it from there.
Fantastic, Lynette, and thank you for the warm welcome, and also absolutely huge congratulations to you and all of the rest of the colleagues. Hang on, spotlight. Okay, I think everyone can hear me. I was getting a pop-up that I could mute myself to speak, but you know, I was pretty confident so everyone had me. So Lynette, I did really want to thank you and recognize the participants of Impact in doing two things. One, I think for having the courage to dive into the hairy topic of care transitions, recognizing that this work is critically important. And two, for the quality and the applied nature of the resources that you've created here. It's absolutely extraordinary. And folks on the line, we are very proud of our Virtual First Initiative Impact that we host in partnership with our American Telemedicine Association colleagues. For folks who may not know me, my name's Jen Goldsack, I'm the CEO of the Digital Medicine Society, or DIME, and I'm delighted to be welcome on stage here today. And hopefully, Ron, you're somewhere where you can pop your video on, and we can have just a little bit of conversation about some of the work you're doing on Virtual First to get us started. And Ron, I'll do you a disservice if I introduce you. So do you want to go ahead and introduce
Jennifer, I am here. Unfortunately, I have an unstable video, so I can't have video and audio today. Unfortunately, I'm traveling. So you might want to hear me instead of see me. It's up to you.
I love it. I mean, ideally, we'd like to do both, wouldn't we?
I'm very
this
sorry.
Will be, this will work just fine. And there's no presentation about the virtues of technology is complete without a tech challenge. So thank you for getting this one out the way early on. Ron, go ahead. It's been a pleasure getting to know you and working with you through Impact. Tell everyone on the line a little bit about yourself.
Certainly, I'm a physician, importantly, a primary care physician, now the CEO of CareHive. I've been working at this probably for 15 years, and I've focused mostly on asynchronous engagement of patients, thinking about patients in a way that they extend from an office visit. What happens when the patient leaves the office? How do you actually communicate and access that patient and their information to promote their health, specifically around chronic disease? And to me, it's always been a data problem. How do you actually access the patient's information and harness it in a way that benefits the system and benefits the provider so that they can apportion the appropriate resources to that patient, and engage them in a space where they can be engaged, which typically is the home. And this idea of transitioning from a virtual world to a clinical world where you might have a physician or a nurse in person, and all of the in-betweens between getting the information, engaging the patient where they are, and then potentially bringing them into a space where they need to be seen. That's really been my passion, and that's really what we've been focused on at CareHive.
Ron, well, first of all, I love it. I just get to sit here and I get to sound very smart while you give me the voiceover. So this is terrific. But I mean, I think you really get to the heart of the matter with this, and why care transitions are so important in the digital era of healthcare. I think we collectively agree as a field, and hopefully this doesn't remain as a sort of misnomer to anyone, but when we say virtual first care, Ron, we aren't saying virtual only, we really are saying virtual first, right? So we need to contemplate this hybrid model, and we also need to think about how we use all these different tools, technologies, different ways of reaching patients, and that flow of data that you mentioned. How do we build that all around the patient and not the clinic? And you asked a really important question. What happens when they leave the office? And I think that that is a particularly important question in this hybrid era of care as we think about the role of virtual first, because there is no reason for that patient to then go off into the great unknown the moment they walk out of the office any longer. That is the promise of the digital era of health, the sort of virtual first approach. Can you be a little bit more specific, though, Ron, about how you are using this data? What flows of data are you taking? Are you making use of to better care for patients?
Yeah, and I always have said, so I'd like to go back to a clinical example when I'm talking about this, and that when I was in my office practice, I would have, 12 people lined up for the day. And often, the first one would have, a pink eye, conjunctivitis. The second one would be a blood pressure check. And then the third patient would be a, let's say, congestive heart failure exacerbation. And I always felt that, for the pink eye, I could manage that like with video. And for a blood pressure visit, I can manage that with information. I don't need the patient to come in. But the heart failure patient that's worsening, I really needed to see that patient. I actually should have seen him or her like first thing. That's the first thing I should be doing. So to me, data is so important in really stratifying the patient population into who needs to be escalated to what category. So who needs a in-person visit? Who needs potentially just a data exchange with a provider or with an AI system? And then who might benefit from simply a video visit? So that's where the conjunctivitis or dermatologic problem might really be addressed. So the primary issue is getting access to the information that will allow you to properly triage and escalate that patient. And that's really what we do at CareHive, is that we leverage data from claims, pharmacy, from EMR, and we build data models to say, all right, in this population, we understand that you have a percentage of heart failure patients, but what percentage of them actually don't have comorbidities that have been actually properly coded? What percentage of them actually were coded for heart failure in 2021, but not in 2022? And how can that affect both your revenue, and how can it affect the patient care? How can it affect getting the patient to the right level of care so that diagnoses aren't missed and patient problems are addressed before they lead to an escalation that is completely unnecessary? And that, to me, is the beauty and benefit of harnessing data.
Ron, it's such a terrific example. And if we follow that through, right, we can see that we provide the best level of care to the patient, right? So we can optimize outcomes while we do a number of other things, right? We can sort of provide the best patient experience. We can also be as efficient as possible within our system, whether that's a sort of cost point of view or an allocation of resources perspective. And increasingly, as we think about those resources, it's actually clinical expertise. That is going to become our greatest shortage at this point. We've been so focused on cost, but this model allows us to capitalize on the sort of clinician expertise that remains within our industry.
Yeah.
How do we take this to scale? And I think this gets to the heart of what we've been working on with the care transitions piece. You do this very well. We have a suite of resources designed to help people, but virtual first only scales if we make it taught to the rest of the system. How do we do that part at scale, Ron?
Yeah, I think, one important piece that you're addressing is this idea of workforce. And again, taking it back to a clinical example, I often felt that the highest level of a provider in terms of education expertise wasn't always needed to address the problem that was in front of that person. So using technology and using navigators and rules to really properly leverage that workforce so that the navigator can appropriately escalate to that right level, whether it's a care coordinator, a nurse, a mid-level provider, or a physician. That really allows you to scale the workforce. And that's where the technology comes in, right? So you're leveraging the technology to build the rules of escalation, and that navigator can then point people and patients in that right direction and help engage them so that they get to that endpoint that is so important to prevent expensive escalations for patients, specifically with chronic disease.
Ron, and as we get to the end of sort of our brief remarks to kick this session off, I think in addition to the data piece, you've just flagged two other really important pieces. Those flows of data, thoughtful use of that data allows us to sort of deploy a very complete solution, that whole person care.
Mm-hmm.
And what I think I heard a little bit there, and it's what I bang the drum on, so I'm definitely going sniffing for this, is that it also gives us the opportunity to almost think about moving care a little bit further upstream. We aren't sitting in the clinic waiting for people to present at our door sick, or because it's the routine 6-month follow-up. We are being much more proactive, and we are capable of doing that. Would you agree? Yeah,
absolutely, Jennifer. And the other thing that you're alluding to is by having these pathways and quantitative measures. So we're actually, when we, especially when we leverage asynchronous, we get streams of data points. And when we collect these data points, we then learn. So we're creating a learning system about the trajectory of escalation for patients with specific illnesses. And we learn with each instance of a patient moving through our system how to better manage that patient to prevent that unnecessary expensive escalation. And for what we do at CareHive, we're really focused on measurement of that. So what we call like real-time ROI, so to speak, so that with every patient we learn and we get better. And from a client perspective, they actually get to see the trajectory of the patient through the system and understand the value of escalation to an asynchronous engagement, to a video engagement, to actually dropping codes, for example. So there's just this idea of proving benefit both to clients and to the patient, because the goal of this is not to wait for an appointment or not to wait for the patient to come to you. It's to use information and to use your technology to go and to come to the patient at a time when they need you before they need to come to you when it's too late.
Ron, you give that such powerful voice, and I think it's such an important call to action for all of us now, right? This is not about reducing these flows of data to dashboards and making the same decision at the same time as we would have done. This is a real opportunity in the digital era where that data is liquid, where ostensibly we should be able to access these things and not once. That idea of that learning healthcare system of being better for patients and for the people who care for them each and every time is absolutely mission critical. And it's been an absolute delight, Ron, not just chatting with you today, and thank you for joining us while you're on the road, It's been terrific working with you and the rest of the Care Hive team through our impact initiative. Absolutely tremendous conversation today. Lynette, let us hand the mic back to you. I know that you have, and Ron, we got you there at the end. Thank you and great work joining us. It's been a pleasure. Lynette, it's all yours to take us through these resources we've been talking about. Ron set the stage beautifully, and you've got some other members of the impact team to introduce us to these tools too.
We do. I'm going to put the presentation back up just for a second here. All right. Okay, so what are we looking at here? We talked to Jen and Ron introduced us to how critical it is that we address these care transitions. And thinking when I first started this project with the impact team, it seemed like an insurmountable task to solve for care transitions. And how do you go about it? Well, you go about it by anchoring the work that you do and the problems you solve to a patient journey. So you'll see a lot of this arrow as you leaf through the resource kit. The toolkit is live on our website, and you can go leaf through it. But the gist of it is, of course, there are 3 really important types of transitions that we need to be able to manage for. And the first, of course, is getting patients into a new practice. And that often is a new diagnosis or a new site of care, or it can be very, very challenging from the information flow, from patient experience flow, awareness and trust. And what really facilitates that has to do with the partnerships that you have in place and the work that you do to properly educate. The next phase, of course, is when you have established patients, either they're following their care journey relatively smoothly, or in most cases, many cases, we have patients with lots of things going on, as care escalations, flares of their treatment. And the co-management term here in green is very deliberate because we're co-managing patients with virtual providers, with informal care partners, patients themselves. And there's a lot that needs to happen to do this smoothly and with efficiency, as Ron spoke of. And then virtual first cannot be virtual only. In many circumstances, there are services that need to be delivered as a part of care that cannot be delivered digitally. So maybe a lab test or new medication, maybe a procedure, imaging, et cetera. That's a problem of finding what's available, what has high value in terms of quality and cost, but also what's going to be accessible to a patient who may be homebound or who may be very busy professional, managing children, et cetera. And so looking at those 3 areas is really how we approach this work. And what you'll find as you leaf through the resources is some major themes came out of this. So first and foremost, a guide to look at what are the should-dos and the how-tos along the care journey, looking at everything from ways that you would build trust and look at data flows, et cetera, to looking at how would you go about selecting downstream services that might be needed for patients. And the 2 themes that really come very, very strongly in this work are you have to have the right partnerships in place, and they have to be very data-driven partnerships. They have to be much more intensive partnerships than what we've seen in the past with various different stakeholders. And so we have a whole kit on really the types of partnerships and what the recommendations are there. And the second is this idea of information flow, not as just a way to deliver effective care in the right settings for the right patients, but also a way to scale our workforce, a way to find high value services. And so this tech stack walks us through tech stack for effective care transitions, really just the top 10 sort of bus stops along a patient journey and what you need to be looking at in terms of making that process much more efficient and effective. And of course, the piece I'm most proud of before we move into the panel discussion is that this is not the future. Maybe it is the future too, but this is all real work that's happening now. And our impact project team that they really drew upon their own experiences, sharing, I think, very generously from what they've figured out and what has been working in practice. So these care transitions case studies, definitely check those out, because this is what good looks like in practice. People have solved the problems. And so the next and final phase of our discussion here, we will move to talk to my colleagues on the project team. I'll stop sharing my screen here, and really have a chance to understand how they're using these concepts of care transitions in their work, and really what their perspective is from their unique seat in the industry. So I'd like to first turn to my colleague, Pete Solano. And Pete, I'll ask you to introduce yourself. And before I was just thinking, what can I ask Pete? We talk so much about what the ingredients are for not just not failing at care transitions. We can all think, everyone on the line can think of all the risks of getting this wrong, right? Patients fall through the cracks, there's delays. But I think, evolved my perspective the more I learn about this field, that we can do this. Virtual First Care has the tools to actually really do care transitions in a much more leveled up way. Yeah. And you're very thoughtful about that. So I'd like to hear your thoughts on yeah.
Yeah, thanks, Lynette, and good to meet you all. So I used to work at a big healthcare system, MedStar, in the DC area. And 2 years ago, I joined Heartbeat Health. We do virtual cardiology nationwide. We have cardiologists up licensed, would really be the word. You could say licensed, but of course, in the Times, they're up licensed in all 50 states plus DC. And we're built from ground up to offer value-based care to at-risk entities, two principal types of ACOs and payers. And we're probably benefiting from what I think is the biggest change since virtual became a thing during COVID, and that's the redrawing of the specialty line. So, America historically has been hyper-specialized in healthcare. If you have a tiny cut on your finger, you feel you need to see the greatest dermatologist at Mayo Clinic. You don't, but you think that. But ACOs, for a variety of reasons that I'm sure good blog post by CMS on this this week that you can read. They're energizing at-risk primary care, serving Medicare patients to handle the low to even moderate end of acuity for specialty. So at Heartbeat Health, we come alongside ACOs and we help them manage low to moderate, but they keep them in-house, and we take on high to acute. So that's that redrawing of the line. In terms of transitions of care, and I'll pause after this, Lynette, for to see where folks want to go and any questions, is the paving of the last mile and liquidity of health records. So virtual first companies probably wouldn't take a patient de novo, especially if they're complex, right? A Medicare patient is probably polychronic, has 3, 4, 5 challenges. So it's so key to us probably to stay to our lane, but also contemplate the totality of the patient. And even though 21st Century Cure's information blocking provision is not yet in effect, health records pretty much flow like water. We find it easy to get the totality of a patient's structured data retrospectively and prospectively. There are a number of vendors for that. So in the business of kind of exacerbation, detection, and avoidance, which I think is a way to consider value-based care, that's a non-trivial blessing, right? We can run algorithms that data to predict trouble. And then the second point relates to what you do when there is trouble. Since you can't see us face to face, what do we do if the patient is escalating? And the answer to that is the radical and rapid paving of the last mile. So Dispatch Health, Medically Home, 2 players have already been acquired by payers, One Home, Humana, MyNexus, Anthem, and there's at least 25 others have the ability in new markets by the month across America to get a nurse to the home in a car with advanced diagnostic devices that can stream in real time. So for all of us, if and as our algos running against our own data, RPM data, the patient's EMR data, detect looming trouble, we don't have to see that patient head off to the ER, hospital, you know the story. We can interdict would be a good word, by ordering up a nurse to the home. It's kind of $400 or $500 if you look at a player like Dispatch, whereas a hospitalization can cost 10 or 20 grand. So we tend to think it's a good arbitrage. That is to say, if there's a 10% chance Lynette is going to escalate and cost 20 grand to the payer and to you as a value-based protagonist, 10% of 20 grand is 2 grand. And yet you could make that go away for a $500 home visit. So I'll pause there. Hope that helps.
Oh, absolutely. And just, I want to point everybody to the chat. So Pete, you've been really instrumental in helping build some of these how-tos in terms of last mile players, in terms of how do you partner with ACOs. And I think that's been, I mean, actually, this is so typical of how we work with the impact leaders, is that you guys are doing this and we're really able to synthesize and translate what you've done in terms of partnerships. And at this point, I think it's a really good segue to bring Jeff Matus on the line, because Jeff has been really, the last time he and I talked, we were really talking about how the virtual first model is really purpose built for those types of interactions and relationships. And one of the really important pieces, I think, of these care transitions toolkit is, how do you partner? And one of the things you said to me really stuck. This model is purpose built for value-based. And Pete was saying this redrawing of the specialty lines. You guys in the work that you do, really, not only are you sort of creating patients as specialists in their own diseases, but you work with the procedural specialty to take on care of the really intensive management and care of patients in the interstices. And so tell us a little bit about how that work is playing out in your model, and how you see transitions in that co-management space.
Yeah, thanks so much, Lynette, and always a pleasure to participate in these events and in this community. So just as a refresher, just to back it up, so my name is Jeff Matus, President and Chief Commercial Officer at Welllinks. What Welllinks is focused on is building integrated virtual first care focused on COPD. So COPD is chronic obstructive pulmonary disease. It's the 3rd leading cause of death by disease in the US and the 5th most costly chronic condition, driving $50 billion of direct COPD related expense into the health system. We know that anytime we hear big numbers like that, there's an opportunity to make a lot of them go away. And the way that we want to make a lot of them go away is by empowering and activating the patient as a core component of their own care journey. So Lynette, to your point, we believe that part of value-based care is redefining value around the perspective and lens of the person receiving that care. So the patient, what we're all here to do and to serve. And not just that patient as a participant or someone who's along for the ride, but someone who, to the extent that they're empowered to be and supported to be, are in the driver's seat. So we think about some really simple stuff here, and executing on it is not simple, but the stuff all makes a lot of sense, just like what Pete talks about at Heartbeat. COPD is an ambulatory care sensitive condition, right? So we know that a condition that's ambulatory care sensitive, if addressed proactively in a meaningful way before any of these big exacerbative events that cost a whole bunch of money, it can be impacted. You can remove a lot of those. You can remove the cost intensity. You can remove length of stay, and you can take a lot of these burdens out of the system just by using healthcare where it's meant to be used, which is in a proactive fashion. So our model is really focused on that, on taking patients in an ambulatory environment and giving them the tools and support they need to be successful in their self-management, helping them out with things like lifestyle modifications and behavior change and exercising more and disease state education and navigating provider decisions, all of that. So we're an advocate for the patient. But then our patients do get sick and they go to the hospital, and when they have to come out of the hospital, we have to figure out how to pick them back up and continue to support them. So where this transitions of care work comes in specifically for us is how do we get patients from a hospitalization post-acute COPD exacerbation into a virtual pulmonary rehabilitation program and try to reduce the 25% of patients that go back to the hospital. The answer is pulmonary rehabilitation. It's the same answer if it's in an outpatient setting in a brick and mortar environment or if it's in a virtual first care setting. Dr. Chris Mosher out of Duke just this week published some really groundbreaking literature on the cost effectiveness, for the first time ever, looking at the cost effectiveness of pulmonary rehabilitation in the United States, and found that there's over $5,700 in savings opportunity per patient who completes a pulmonary rehabilitation regimen. You know how many actually do? 4%. What's the problem? Lack of access. It's a 10-mile drive for most people. Gas prices are pretty expensive. If we look at the population that's living with COPD, it's not the ones that have extra money to spend going to and from doctor's appointments every week or pulmonary rehab appointments. It's inconvenient, so it doesn't fit into the lifestyle, so people stop doing it. And reimbursement for those who are delivering pulmonary rehab is terrible. So there's a lot of things we can address there, but one of the things that we can do is use virtual first care that we know is proven to be non-inferior to care delivered in an outpatient setting. But that's obvious, and that's the easy stuff. The hard stuff is saying to a health system, how do we get your information from that data-rich environment into our program so that we can leverage it to its maximum benefit for your patient? So I need to know what medication they're on. I need to know what the discharge instructions are. I need to know if they have supplemental oxygen. And without all of that information, even the best intended plans are likely to fail. So we spend a lot of time with our partners thinking through how do we actually get the information from inside the walls of that institution into our system. How do we figure out when something does need to be escalated or de-escalated or a site of service needs to be changed, who needs to know that and where we can direct folks and make sure that we're part of the system, not ancillary to it. And through that combination of giving access to things where there's no access today, but there's proof of effectiveness, improving the flow of information and letting rich healthcare data do its job and support better patient care, and being thoughtful about how virtual first care and brick and mortar care can harmonize. I think that's one of the recipes for value-based care. And I'm excited. I think we're at day one, but I'm excited to see how through resources like the toolkit that we're launching here today, we can try to approach that at scale.
Thank you. You said exactly what I was hoping you would. So everyone definitely check out for more detail on what Jeff is doing on the case study. One thing that and hopefully I'm not speaking out of turn, Jeff described when I said, so how does value-based work? Because pulmonary rehab is not well reimbursed, and it should be because it's very effective, but how do you work? And thinking about building a model with a partner that reimburses based on outcomes that matter. So are the patients engaged? Do they complete the program? That's level one, right? The next level is, are they getting better? And that's some brave, I think, very courageous work moving into actually measuring, are patients getting better? Are they going to graduate from this program? Are they learning the skills that they need? So I love it. And the inspiration for thinking in this way really derives from folks like Dr. Tygeson from Buying Benefits. And I'll call Dr. Tygeson up because I think you're one of the first people I met when I joined him. He said, we must move towards outcomes focused and goal driven care, and the incentives have to align up for this. And when we think about what are some of the barriers to care transitions, the first thing that comes up is misaligned incentives. And what I want everyone in this program to take away is there are people navigating this right now quite effectively. So I'd like to hear from Dr. Tygeson. What are your thoughts then on you're putting together these models from the payer side? What would you like to see more of? Where do you think we're going and need to go?
Well, thank you, Lynette. Yeah, and I'll try to be concise. So number one, I mean, we at Bind, and I would say more generally United Healthcare, because Bind is now part of the United Healthcare ecosystem, are very excited about what's happening with virtual first providers for all the great reasons that you've heard from Pete and my other colleagues about the potential for these new care models to really drive much better clinical outcomes as well as more efficient, affordable care. when I think about sort of how we think about this at Bind, I would say that number one, we see ourselves as very active agents and collaborators with respect to the first part of this recipe, if you will, facilitating the engagement and onboarding of our members with virtual first providers. And we do that through our benefit design, giving either making virtual first providers free to our members or very low cost. And then also we do a lot of active promotion of virtual first providers, either in lieu of or in alongside of complementary to the care that our members are getting from their in-person brick and mortar providers. So that's a place where we have a lot of agency, and we're working, trying to work really in partnership with our virtual first providers in network, if you will, to promote their services to our members in a contextually appropriate way. So based on what we know about their conditions, their state, if you will, we want to make sure they know about the availability of these very special care alternatives. Another way in which we're very actively involved is trying to work with our provider partners to help them steer people to high value in-person care, downstream in-person care, when that's something that's an important part of their care. So for instance, we're just launching a pilot with a virtual first provider in women's health right now, where we're actively collaborating to make sure that we have compiled together a list of high value providers that we know are cost effective and believed to be high quality, and cross referencing that with providers that this virtual first provider is establishing partnerships with, that they have confidence in terms of their clinical skills, so that we have come up with a subset, if you will, of providers that we both have confidence in as being high value. And we're very interested in evaluating how that's going to drive even more value from this engagement. It's not just that there's value in people working with this virtual provider or a virtual provider, but also there's tremendous value in the steerage effect in terms of guiding people who do need that downstream in-person care to high value providers who are going to be delivering the best care. The second element of this really has to do with sort of the collaboration between virtual first providers and in-person providers. And this is a place where I think the plan has maybe less of a large role here, particularly a plan like Bind, where we don't do our own direct contracting and provider relations for brick and mortar in-person care. We rely on the relationships providers have with the United network. And there, I think we look to our virtual first provider partners to establish those kinds of working relationships and close those last miles of care for things like diagnostic testing or common procedures. But that said, I think health plans do have a big role there, and certainly can work with existing brick and mortar provider relationships to try to encourage the adoption of high value virtual first care. I think there is some natural, the psychology of in-person providers is often sort of not invented here, or concerns about competition from other providers. So I think there are some challenges there, but I have reason to believe from talking with people like Pete that some of those challenges can be overcome. Anyway, bottom line is plans have a huge role to play here, and we're very excited about these innovations and are eager to accelerate the work.
Love it. Thank you, Doctor. I think that my next best panelist here to add would be Chris Kaya from representing Aetna, because Aetna, again, you are another large payer, CVS also a provider. And so you announced that you're putting together both the virtual and the in-person primary care and specialty care networks. I'd love to hear from you, sort of your follow-on to what Dr. Tygeson said. How are you at Aetna thinking about curating those high-value networks that I would call them a hybrid network? and what role do you see yourself playing in terms of facilitating the care transitions and the relationships between bricks and mortar and virtual providers? Again, both internally as a provider, but also as a pair. It's a big question. Chris, you're muted.
Can
There
you
we
hear
go.
me now?
Yes, sir.
All right. All right. Well, we'll make it work. So as I was saying, we're somewhat natural, kind of curators in the environment, whether it be through, the products, benefits that we design, how we structure, our networks, or what tools that we provide to our members to help them navigate the system. And where there are opportunities to partner with providers that have a strong digital presence, as well as a strong in-person presence or strong partnership network to provide that in-person part of the care, it's hugely valuable to us as we think about and prioritize the solutions that we like to bring to market through the lens of our members and the experience that they are having with getting their care and being able to navigate the system, right? And where we can get those things to harmonize, whether it be through getting appointments and setting up referrals and having that data transition along with them throughout the journey, so that each interaction is building upon what has already been done. It creates such a better experience for our members, creates a lot more efficiency in the system. It helps promote kind of a more optimal timing and location and level of services. And when you do that, I think it just creates a windfall of benefits from capacity within the system, the experience of the individual, and then as well as the outcomes and the economics behind that. So everybody in that system ends up winning if you can kind of get that experience right, and that transition is key to that.
So true. And we talk a lot about sort of matching the virtual first care product with the pair product lines. And from where you sit, there's so many different product lines, but ultimately one of your biggest stakeholders are the employers. And we're fortunate, again, at Impact to be able to have you at the table, virtual first care, but also Mercer at the table to represent what are the ultimate sort of purchasers of care looking for. And one of the things I urge everyone to watch for, earlier this year, the OMADA as well as Rock Health and the Digital Medicine Society did a survey of virtual first and virtual adoption and attitudes throughout the ecosystem, but employers, where I think results from about over 900 employers really showed us, and you'll see that the work published over the next few weeks, I think, but the preliminary results really showed employers want virtual. They want it for the outcomes as well as the engagement and the experience for their employees. They're thinking about not only a strict traditional ROI, but an ROI that is engaged employees who are productive, who employee retention, things like that. But they're really concerned about adding more point solutions that don't communicate and further segmenting patients away from primary care. So after we saw the survey results, and I don't think Elizabeth had seen them. Elizabeth, I'm going to call Elizabeth from Mercer up, but she told me the exact same thing. So I want to hear, Elizabeth, what your perspective is, what you're hearing from employers that are, I think, much more actively engaged in putting together very high value services. And how, we wrote a whole story together in one of the quick start guides. How should we think about partnering with employers in a way that does facilitate care transitions?
Thanks, Lynette. Yeah, so I'll just say, I'm part of the Center for Health Innovation at Mercer, and we're a group of national experts dedicated to driving market change, specifically through employer-sponsored healthcare. So that means we create and deliver solutions for employers, but also while monitoring the digital health startup market. So this is a really exciting intersection for us, and we're happy to be participating. And so you heard a little bit from the payer perspective, but when we talk about the employer as payer, COVID highlighted some pretty unique challenges that virtual first care is specifically positioned to address. So equitable access for hard to reach populations, but also convenience for those with access perhaps at a brick and mortar facility, but constrained time. And so I think that's why we've seen kind of a staying power in the willingness to use virtual services as consumers become more familiar, the technology gets better, we're just more likely to continue using them. So employers are really eager to understand how virtual first care fits into their overall strategy, kind of for all those reasons. So access, quality, and cost. And so as Lynette was alluding to, the survey was really interesting. I think they're continuing to compile results and should have them to publish fairly soon. But that the biggest thing on employers' minds is how do we offer choice and fill gaps, but create or maintain an integrated ecosystem. So I think we can argue that healthcare varies in the level of integration and perhaps errs on the level of fragmentation. So I think the biggest thing when we think about transitions of care from the employer and member experience perspective is how do we keep that experience consolidated. And we see the interest from employers being in driving them back to primary care. So virtual first care might not always be primary care, but it's important to understand and be able to articulate who's on first and maintain a tight handoff, whether that's through data and information sharing or actual co-management, live co-management. But we really want to position primary care as the entry point to the member journey and make sure that there can be some sort of consistency for the member to make sure that they don't fall in or out of care based on what they're receiving virtually. And I think it's important from the employer perspective to understand where a virtual first solution fits. So is your value prop to them that you're standalone and going to replace part of the ecosystem that's broken? Or will you be integrating, if we use a network, for example, are you a high value offering that they're already potentially have, it's just an enhancement. And I think what's perhaps interesting and hopefully continues to bear out in the survey is that cost is not necessarily king. Obviously, we want to avoid duplication and waste, but to the extent that care can be more efficient, we can keep people who need to be in care and might otherwise not be in the system further upstream. There's some tolerance for cost, but that we should be able to demonstrate a return on what that kind of tight co-management means to their overall healthcare expenditure.
Thank you for that. Sorry, I had myself muted. One of the points you made that really stands out to me, Elizabeth, is getting access to people, employees, for instance, who would not otherwise be in care. And the segue that I like to think about are there are so many conditions that are stigmatized or otherwise very difficult for people to get access to care, and they simply will not. And the next, I think, really good story to think about is one that 30 Madison has probably. I saw the story at the American Telemedicine Association that there is a self-contained solution that is private and efficient and affordable for people who are at risk for contracting HIV. So getting access to individuals who are at risk, getting access to the PrEP program, such an interesting problem, considering that We have people all over the nation, and you've got various different attitudes. And when you think about sort of self-contained solution, I'm on the phone with a doctor or telemedicine, and they mail me the tests and they mail me the drugs. What happens if there is an escalation or a diagnosis? And that's where I think a lot of people think this is where the breakdown could happen. And we specifically wanted to talk to Akhil Shah about how 30 Madison does connect patients to care downstream or upstream when that happens, because there's a huge risk of patients falling through the cracks. And I think you do a really nice job of managing that. I'd like to hear your perspective as in that space and other things that you're working on.
Yeah, sure. Thanks, Lynette. So for those of you that don't know, so my name's Akhil. I work at 30 Madison, and 30 Madison's goal is to be the premier healthcare company for people living with chronic conditions. And today we're treating somewhere between 750,000 to 1 million patients actively on our platform via a combination of insurance coverage, employer, payer partnerships, and even cash pay. And we support patients along the continuum from like their initial diagnosis to receiving treatment and then ongoing condition management. And from a brand perspective, we've actually gone to market with 6 brands or specialty areas that cover about 20 or so conditions. And so first to market on the very lower acuity side was men's hair loss, Keeps. We also got one for allergies called Picnic. And then as we think about higher acuity conditions where our connectivity to the healthcare ecosystem is paramount, we think about our offerings in migraine. So our brand Cove, sexual reproductive health, HIV, STI testing through Nurex, dermatology, things like atopic dermatitis, psoriasis, some higher acuity dermatological conditions through our brand Facet, and then things like IBS or IBD through our GI brand Evans. And as we think about our connectivity and the competencies, capabilities we need as virtual first providers, we think about it through the lens of owning the patient experience. Patients come to us as we think about access, convenience, and this notion of conditions also that may be heavily stigmatized, anything from HIV or STI testing to even things like IBS and IBD heavily stigmatized. They're coming to us because they trust us in terms of the care model that we have, as well as the ability to have access to specialists that sometimes it's sparse or hard to find specialty care. There's long wait times, or typically care in these condition areas or specialty areas. It's a combination of jumping to a primary care physician, a specialist. You go for imaging, labs. Maybe you need to be referred out for behavioral health and cognitive behavioral therapy, nutrition. You're going to 100 different places to get the actual integrated care you need. And so our care model helps account for that. And so as we think about our connectivity to the healthcare ecosystem, it really is through the lens of patient preference and patient experience. And so we are taking ownership of the entirety of the patient journey. And that is, I think, one of the things that makes our care model different. It's really making sure we have the ongoing touch points with that patient, and whether or not we can actually draw the lines and have the clinical protocols and care pathways where we say, this is kind of as far as we can go. Anything beyond that needs in-person care. We make sure, obviously, technology-wise, data sharing-wise, we've got the capabilities to enable that. So some level of interoperability to enable that. As was mentioned, the entire healthcare ecosystem is all over the place, right? So as you think about some kind of smaller, more rural areas that we're operating in, some things are just done by fax, and that's a capability we need to be able to support. As you think about some of these areas and higher density urban areas, we're actually coexisting with other broader, large healthcare systems or large radiology groups or whatever it may be. We have healthcare interoperability through data partnerships to enable the exchange of relevant clinical information so that from a patient experience perspective, it's seamless. As you think about other core competencies though, I think it's also really important to think about what kind of partners you're working with, and it's not a haphazard experience about sending someone out for imaging or sending someone out for maybe a endoscopy, a colonoscopy, and they're getting a redundant workup. So how do you build relationships in that community and have an understanding around also SLAs in terms of turnaround times on some diagnostic testing that may be needed, or whatever in-person care, access to in-person care that's needed in terms of ability to get appointments. And so we spent a lot of time also thinking about in communities where we have large footprints, how do we create that relationship and have some SLAs? And so as we think about the patient experience on a macro level, even things that are outside of our direct ability to treat, diagnose, or manage care for that patient, we're taking accountability for the patient's care in person as well. And we want to make sure that the experience that they're getting there is an extension of the experience that they get through 30 Matus and some of our brands. And that's really the approach that we've kind of taken to making sure that it is a cohesive experience along the patient's care journey.
I love that. So what I heard you say is taking ownership and accountability for the experience of the patient, even when they're outside your care, which means the partners that you work with or you select very intentionally. And to do all that efficiently across the whole United States is a lot of work. So you make great use of interoperability and data streams where you can. And check out the case study. I think that I really enjoyed working with the 30 Madison and the New RX team on what happens if a patient does test positive with HIV, and all the work that you do to make sure that that patient is not lost to follow-up, and checking in with them. So that I think as a cancer survivor, a lot about what happens when you're done treatment. It's not over for you, right? And who's making sure, how are we transitioning patients out back to primary care, maybe with a care plan that keeps them through. And I think that's a perfect segue to talk to Shelley Lanning from Visana. Shelley, you have worn a lot of hats in your career and have such a broad perspective, but I'd like you to tell us about a little bit about what brought you to Visana, women's healthcare. You know, hold up half the sky. It's a absolutely appreciated women's chronic health disease. What have you been doing at Visana to do that difficult work of connecting with primary care, embedding full service, complete solution women's healthcare? That's one question. And then the other hat that you wear that's, I think, so valuable to this group is you have this 30,000 foot view as an investor who's been watching this field evolve and trying to pick what to look for in the companies that are going to be successful in transforming care. So to pick whatever question's more interesting to you, but I'd love to hear your thoughts on both of those. Yeah.
So just a quick background, just provide a little bit of context. I've been in healthcare my entire career. I've spent the last 22 working in private equity and venture capital, all in a healthcare focus. I've taken a couple of different stints as an operator. So bought a company, ran the company, sold the company, and then came back into investing. I like women's health. I've got several investments in fertility and family building, fetal maternal, and I funded Visana Health, which is providing healthcare for women from menstruation to menopause, with the exception of family building. And I funded this company in February, March timeframe of this year, and then recently joined as a co-founder. So I wear a lot of hats and have perspective, and I can say without question that the drivers that we all care a lot about are really very different. We wear a different set of lenses. So while without doubt, we all want to get from point A to point B, we want to have great patient care. We want to save money. We want to have better access to care. But the way we get from A to B is very different, and perspective is different. Venture capitalists have a different investment thesis than what a payer might have, or what a self-funded insurer would have, or employer would have, from what an entrepreneur would have. And part of what we do is we've identified these as problems. There's a shortage of doctors. There is a lack of connectivity. There's lots of silos in healthcare. But what I've found that's been really helpful in the work that Dime has been doing in the Impact Group is to streamline what the problems are and go beyond those big macro problems, and to be able to say, okay, we all know there's a stress point on our clinicians and how we get all the data connectivity. But they go further and they say, well, let's look at the contracts. What do we all care about? Virtual care is very different in a data collection, in a laws and responsibility, in a clinic and how we get things done. And people weren't prepared necessarily to understand why is that different from brick and mortar and how do we fix that? So the tackling of each of these topics is really relevant, and it's brand new. It hasn't been here for 5 years to be focused on. A lot of it is real time. So I look at what 30 Madison is doing from a company perspective, and they're paving the way for a lot of us. But I'll bet you they're doing things differently today, post-pandemic, than they were beforehand, because the trajectory of how we're all working has changed. So I like a lot of the work that we're doing to streamline, identify the problems, be able to have a toolkit or a basket of the things that every single one of us, no matter our lens that we're wearing or our point of view, can draw upon to know what each of us will care about. And I also said I really enjoyed being able to interact with the United Health Groups and the Binds and the Aetnas, and then the entrepreneurs and the self-funded insurers, and really understand the ecosystem of what people care a lot about and how we can make this a smoother process for all of us. It's been really a great experience.
Thank you, Shelley. That was perfect. And you reminded me, folks on the line, you're looking at these resources and hearing from this group of amazing project leaders and steering committee leaders from Impact. Maybe you're wondering, how do we come up with all this content? One of I'm always a little interested in process, because like, well, did Lynette make all this up? Absolutely not. These folks are on the phone meeting with us every week for months and months, and giving their time. And one of the things I love the best is we got 65 of, I say, probably the top experts in this field together for a 4-hour workshop. And it was literally, I would say, we anchored everything on how does the patient flow through the system, but we're very, very deliberate about what are the barriers and frictions that a payer may be running up against? What are the constraints of the health system that you will need to partner with? What do they care about? Well, is it clinical trust? Is it payment? So really hearing from each of these stakeholder groups, and the voice of our patient experts was so clear and so strong, guiding us to, putting that hand up and saying, listen, this is a very scary moment for patients, and you're forgetting a whole field of folks that are the informal caregivers. They're not paid. They didn't necessarily sign up for this job. They are absolutely essential to making sure patients get where they need to go, to understanding how to use their tech, et cetera. And my wonderful colleague, Jerry Lynn, is on the line, and she can represent some of our patient expert view. You're the one that said, Lynette, you're completely forgetting about the caregivers as important partners in making all of this work. And I'd love to hear, so I'm giving Jerry Lynn the big job of sort of wrapping it all up, because if we don't get this right, patients suffer the most. I mean, our providers absolutely will, but all of us are caring for patients, or patients ourselves, caring for our parents, our children. We've got to get this right. So Jerry Lynn, I want to hear from you. What does everyone need to do? What's the takeaway?
Well, I think it starts by making sure that family caregiver and care partner is like part of the design team. Are you not just testing things with patients, but with family caregivers? Because increasingly, yes, my mom has heart failure, but I'm really the one who needs to look at her chart and understand everything. And oftentimes those people are too ill, or of course, increasing age makes things challenging as well. And I need to, completely think about my schedule. We talked about employers before. People aren't just patients, they're also family caregivers. And even back when I was doing design work to create care transitions virtually, whether it's interactive voice on phone calls or multimedia videos, though you have to educate the family caregiver as much as, and sometimes more than, the patient to make sure they understand what's going on. So I think health literacy plays a role in this, and that has nothing to do, as we know, with the person's education level or even past experience as a patient. Even people who have been living with conditions for decades are sometimes don't know what they don't know, and that's also true for the family caregivers. And so sometimes we take for granted, first of all, that both patients and caregivers understand very basic things about their health conditions. Again, with heart failure, I had very educated people think that it was just not a chronic condition, that it was something they were going to get over. You know, so we hear these types of things all the time, and you realize, oh, are we giving people what they need to understand that their participation, both as a patient and a caregiver, is important, like understanding that why and that what possible, how can they participate and use these tools to better navigate the system, and safe, because people are really, really scared that they're going to somehow be responsible for hurting or not taking care appropriately of the person that they love and not knowing when to call. And I think that's where these systems can be so powerful. So it's everything from, you know, like proxy access. Like I have a hard time just logging in to look at things that my mom signed up for because they want to send the access code to her. And I'm like, but I need it. I don't want to get locked out. And so there's all of these challenges. And I think, you know, there's huge opportunity to do a lot of these things people have been talking about, like build those relationships so that when I am talking to the doctor, I'm using the time as best as I possibly can when I'm interacting with them virtually or in person. I'm asking smarter questions. I understand when to call, or in many cases, these systems are helping to alleviate some of that burden we all have about, well, when should I be calling? And how do I know if this is an emergency or not? And so I think that these systems can really help when it seems things always happen on a Friday night or a weekend or whatever it might be. And so really making sure that both we're testing these resources with patients and families, and that we're making sure that they're not disintermediating, but actually supporting and improving that relationship with the clinicians and the care team.
Brilliant. And I can't remember if we dropped a link, but yeah, there it is. A guide to engaging care partners. Again, opportunities along the patient journey to identify who these helpers are, make sure you understand their roles. And so I think what's different with virtual is something I have to keep asking myself. Are we just solving the problem for all of healthcare? In some cases, yes, right? But for virtual, even more important to make sure that our caregivers and care partners have the right education around using the digital tools, and using the digital tools in a way that makes it easier for them than it would have otherwise been. So, and the other, I think, very, very strong voice on the team, Karina, is a patient who's been a patient expert who has been guiding. Is Karina on the line? Danielle is going to promote Karina. Wait just a second. Waiting for one of our other patient experts. We'll come back then. We'll come back. So I wanted to leave a good, oh, there she is. All right, so Karina, I want to give you the mic to add comments. Again, I think our patient experts should have the last word in this. What are we missing? What's next? What do we really need to focus on, Karina, as we move forward with this work? We're not done with care transitions. I really see this as the start. What's your, what do you want people to take away? We're on the line.
I really want people to remember that the whole reason we even engage in any of this work is the patient, and that we all play a really key role in helping the patient live a better life, even if that life involves having a chronic illness and ongoing health issues. We can't, in all our discussion of digital systems and how to make money, and what's the most efficient way to do healthcare, we can't lose track of the fact that it's really all about people ultimately, and that those people, us people, I'm a patient with a chronic condition, we're the reason this exists, and we're equal partners as well, even if that means we have to have somebody stand at our side as a caregiver, as a translator, as some kind of connector. We really need to have equal footing in order to ultimately have all of us deliver better care.
I love that. And I think many of us have been patients, myself as well. Karina, such a strong point. If we do this well, our patients have a wonderful experience. Our providers do as well. I think that the worst thing we could do is digitize this system and lose sight of what we really ought to be focusing on is, you said, getting patients well, and that strong relationship between a clinician and the patient. That might not always be digital or virtual. It might be the radiation tech who is holding your hand during a scary, scary procedure. That's what they're doing. And it makes all the difference in the world. And so our digital technologies, all the smart AI, that exists to make that relationship easier and scalable. So with that, this is our opportunity now to bring all of our panelists back and take some questions from the participants. And I've obviously have some questions in the back of my mind of what I would ask, but I'll pause and will please type your question into the chat, or again, you can raise your virtual Zoom hand by doing, let's see, did that work? Raise your Zoom hand by clicking the little hand at the bottom, and we can have you ask your question live. And that goes for you too, panelists. I know you all have lots to say, so let's see, is there anything coming in? While we're waiting, this is my favorite question as the scientist. I want to know what's left to do. What do we do next as the impact group? Obviously it's a little self-serving because I'm excited to build on this work to get going on the next series of problems. Impact team. Anyone want to take that?
I have one idea, Lynette. It's evidence, right? I keep hearing the word dearth from people. You digital players, you virtual first players, you seem sometimes that you have a relative dearth of evidence. And I know that is not a compliment. So what if we were to come up with some kind of standard framework? Because I've seen some great white papers from virtual first companies that do have terrific evidence, but they're not very comparable, right? Apples to apples. And as I said earlier, so many of these patients are polychronic. So I would vote for some kind of rubric on evidence that we could potentially all follow, thus making the at-risk entity's job so much easier.
Mm-hmm.
Yeah, if I can piggyback on that, I think producing evidence that is, like using kind of a new and innovative, what I would say, clinical quality framework as well, that's really more focused on not just process measures, but outcome measures, and not just outcome measures that matter to us as physicians, but outcome measures that actually matter to patients. And I think that would be a great body of work for us to work on, because I really, one of the things I think the virtual providers really have an opportunity for is to advance our thinking in this space beyond what I think are sort of blinders that traditionally we followed, based just on this sort of classic evidence-based medicine framework where the agenda is largely driven by physicians and not by patients.
Mm-hmm. Yeah, that's an excellent point. As a health economist, I like to see frameworks in place. And in our traditional healthcare system, the frameworks for evidence are, you said there's a dearth of evidence in virtual first care. There's an absolute dearth of very good, robust evidence for a lot of the things that we do. And rather than holding this industry to a separate set of standards, I do think there's an opportunity to raise the bar in what quality care looks like and continue to push what Dr. Tygeson said is outcomes that matter to patients. And some of our work at DIME is also focused on digital measures, starting to get into what really are the more real-time measures of outcomes for patients.
And to bring the patient voice into this, I really would urge all of the players here to really focus on, when you do your research, when you write your papers, get a cross section of patients, age, economics, access to healthcare. One of the big arguments about digital health is that it can be everywhere all the time for everyone. Prove it. That's my challenge to you. Prove it. And don't prove it by just testing the people you know, the usual suspects, your friends, your family. You got to reach beyond your inner circles to really reach all the communities that could potentially be dramatically and positively affected by your work. And every conversation I have with somebody who's in digital health, they have that altruistic bent. That's what they say they want to do. And I'm just saying, keep that in mind and pursue it, and you will achieve it, and the world will be a better place.
I think that's a good point, and I would just add something we've been talking about also is equity. So does your solution work if your patient doesn't have broadband internet connection or can't connect via video? I think access doesn't, just because it's digital doesn't always mean it's easy for every patient. And so I would just +1 to what Ernest said.
See. Oh, there's a great question in the chat. If I want to, I'll pose this to the group. Just read it. There's been quite a bit of discontent with virtual first in the UK. And how has virtual first fared in the US so far? Do you think engagement and uptake will be a major issue across older age groups? So I think to distill that, I was kind of channeling my mother. Oh, they couldn't get me in, so they made me just talk to someone over the phone. It's second-class care. Second-class care, she's being pawned off. Or are our older groups in the US engaging with virtual? Is it being built for them? I'm curious, what do you folks think? Panel.
I think the age-friendly design is a huge issue. When you watch anybody try and find things, buttons that don't look like buttons, things that are too small of targets to hit, it's really, really challenging for people, especially because so many interfaces keep changing over time. And so they finally get used to something. And I think that's a huge ongoing challenge, is to learn how to improve that as people's vision fails, as their hearing fails. Like, it's really hard to think through all these things, but it's so important to, as you were saying, Karina, make it accessible to everybody and make sure that it actually works for everybody. I think the other piece that is really important to look at is, in fact, how do these affect clinicians and care teams? Is it in fact making their lives and their relationships with their patients better, or is it causing some new problems? Because I think there's been a lot of backlash just based on physician experiences with EMRs and how that has made a lot of things worse for them instead of better. So I think we have to proactively show them, because I think implementation is always a really big challenge. And I think, unfortunately, many of the experiences clinicians have had with EMRs have made those barriers even higher.
I'll add to what Jerry's saying here. I agree with 100% of what she said, with the one sort of different point of view, in that all of these things are super important, but if we wait to get it all right, we'll miss the opportunity to provide for a whole heck of a lot of people. I ran one of my ventures as a operator. I ran a home health agency in the South. And this was before we did anything virtual, where we were doing virtual. And she's very right. It was really difficult for them to bind the buttons and have the dexterity. However, more often than not, they had a caretaker. They had someone who could help them a little bit, to where it certainly wasn't perfect for everybody, and it was limiting for a lot of them. But we were able to provide more consistent care for more people. And I would just say that while it won't be perfect, if we wait for it to be perfect, we'll never get started. And so I'm a really big fan of just saying, lean in, push forward, one foot in front of the other, and we got it. It just won't be perfect.
That's exactly what this impact group is shown. Actually, I think if we look at case studies, we look at the resources, there are so many barriers and so many things that aren't perfect yet. But we can show this is real now. Here are the workarounds. Here are the technologies. Let's go. And I love that most about this group. And we're at time. So my wrap up, instead of going back to a slide, is to say, hey, everyone on this line and people who couldn't join us, the impact group is fabulous. You guys have really, I feel like we're just getting started, but you've really set the tone for building this ecosystem in a way that we're not digitizing bad. We are really setting up for transformational healthcare. And so I would urge everyone to check the resources out, check out DIME on our website. And if you want to be part of this conversation, if you would really interested in sitting here on the phone with these folks, consider joining Impact. Our joining session, membership session opens up within the next couple of weeks, and we'll have some information sessions. I really need a very broad stakeholder group, so everyone's welcome. Reach out to me, and look forward to speaking with you. Thank you all so much. This is great work, and I'm excited to see it out there in the world.